and because the association of COPD with other risk factors such as hypertension, peripheral vascular disease, and poor left ventricle function, patients with COPD have compromised long-term survival after cardiac surgery. We need to differentiate between the exacerbation of COPD and the exacerbation of heart failure. We assess the patient by chest X-ray, but sometimes we cannot to differentiate between this. We can use the BNP level. BNP level more than 500 is suggestive of heart failure. BNP level less than 100 indicate COPD. And also we can use BNP level to evaluate the left ventricle function. BNP level less more than 385 is a predictor of post-operative left ventricle dysfunction. Upper respiratory tract infection is the reason to cancel surgery. We should look for coughing, respiratory symptoms. We look for, say, reactive protein as infection marker and chest X-ray. Active smoking patient should be advised to stop smoking at least for a week. It is preferred to stop smoking 2 months before the surgery. An active pulmonary or bronchitis process, the patient take a course of antibiotic before surgery. Some patients with chronic high dose of amiodarone therapy are prone to have pulmonary toxicity and adult respiratory distress syndrome. We should to stop amiodarone before surgery or at least to reduce the dose. GI history, we look for upper GI bleeding from peptic ulcer because that will increase the risk of post-operative bleeding, and we should start proton pump inhibitor as soon as possible. Avoid non-steroid analgesia in at high-risk patient. A history of alcohol abuse, identify potential problem with intraoperative bleeding and post-operative hepatic dysfunction and agitation and alcohol withdrawal. History of liver cirrhosis. History of liver cirrhosis increase the risk of mortality, and we should classify a patient according to child score. Class A cirrhosis increase the mortality will be 9%. Class B cirrhosis operative mortality 37. Class C mortality more than 52. And we should consider the off-bump surgery because the risk of cirrhotic patient is with cardiopulmonary bypass. So we should consider off-bump surgery. This is the child score, and we should classify all cirrhotic patients according to this classification. Diabetes increase the risk of post-operative risk of stroke, infection, and renal dysfunction, and operative mortality even after off-bump surgery. Also decrease savinous vein graft patency. Mortality risk increased 4 times when the hemoglobin A1C more than 8.6. Renal history, patient with a renal dysfunction and acute deterioration, it may or to delay surgery. Dialysis patient should be dialyzed the morning of the surgery or night before. History of transient ischemic attack or stroke, we should ask about that. Dementia in advanced cases is contraindicate the surgery. Previous chest radiotherapy mandates CT scan, aorta may be calcified. Malignant disease should be evaluated and metastatic contraindicated surgery. We should ask about urologic symptoms, and we should treat the symptoms will suggest of infection, UTI, and we should treat the infection. We should ask about psychiatric history. Physical examination, we should look for general inspection. We should see if the patient is comfortable at rest, require oxygen, obese or cachectic. We should look for active skin infection or rash and treat it to minimize the risk of external infection. Dental caries, we should treat the patient before operation, prosthetic mitral valve. material valve. Hand and forearm, we look for nicotine staining or stigmata of endocarditis, splinter hemorrhage. Carotid bursae are marker of carotid disease. And that will increase the risk of stroke after surgery and increase mortality. We should see bilateral arm blood pressure and a differential systolic pressure of more than 10 may identify significant subclavian artery stenosis. We should look for in the chest for inspect for scar and palpate the apex, the presence of the heart murmur, abnormal heart sound in the when the patient is admitted for coronary and evaluate the patient in the clinic, and then he develop a murmur. We should evaluate the patient again for look about the new disease. Peripheral vascular disease must be assessed carefully. We should look for all pulses, carotid and peripheral pulses. The presence of varicose vein and history of DVT have a potential problem with a conduit for CABG. The test for suitable of radial artery, we should do a Allen test to check for the suitable of radial artery to do to assist if we need to take the artery for a graft. We should take a baseline pulse oximetry, and if the pulse less than 90, you should take IBG, baseline, vital, and ECG. Routine laboratory test, we start with CBC, hemoglobin less than 10. In emergency case, we should not we should not push a patient if the hemoglobin less 10 unless the case is emergency. Hemoglobin less than 10, the patient will not benefit from blood transfusion because the risk of graft thrombosis is high. A patient hemoglobin less than 8, here we consider the blood transfusion. White BC is a marker of infection. If it is high, so you look for the infection. We look for the platelet, especially if the patient on heparin, and that will suggest heparin-induced thrombocytopenia. We look for coagulation, biochemistry, liver function test, ALT and AST is causing high risk of adverse outcomes after surgery. We look for cross-matching, MRSA screening, swab, urine analysis, and pregnancy and sickle cell test. Imaging, we start with the chest X-ray, posterior, anterior, and lateral. Trans-thoracic echo, we need a new trans-echo. Trans-thoracic with 3 months. Transesophageal in the case of valve surgery or infective endocarditis. Coronary angio for a patient with, undergoing CABG. For non-CABG patient with the risk factor, coronary risk factor, CT chest for the case for redo surgery, abdomen pelvic CT for TAVI, band CT in case of infective endocarditis, carotid MRI if we have a doubt about the viability of the cardiac muscles. Carotid Doppler if there is a history of TIA, CT brain of the history of stroke or history of previous TIA. Upper and lower GI scope if the patient have a GI bleeding. Now the adjustment of medication prior to the surgery, we start with the aspirin. Aspirin should be continued until the day of the surgery because they decrease infraction and the operative mortality and improve graft patency and outcomes of CABG. Clopidogrel stop for 5 days before the surgery. Ticagrelor suggests to be stop 5 days. Also, Elbrasogrel 7 days. Abixamab should be stopped 48 hours. Heparin, unfractionated heparin should be stopped about 4 hours before surgery. If the patient high risk critical coronary artery disease, is best to continue heparin into the operating room. Low molecular weight heparin and enoxaparin is recommended to the last dose should be given 24 hours prior to surgery to minimize preoperative bleeding. Warfarin should be stopped 5 days prior to the surgery, and the INR should be rechecked with 24 hours before procedure. Bridge anticoagulation is not necessary in low-risk patient. The non-vitamin K antagonist oral anticoagulant should be stopped 48 hours prior to the surgery. Indication for bridge therapy if the patient undergo mechanical mitral valve replacement, mechanical aortic valve replacement with any thromboembolic risk factor, example, arterial fibrillation, prior DVT. AF at a risk for embolic stroke, CHAD score more than or equal 5, venous thromboembolism with a preceding 3-month history of prior thromboembolic during interruption of anticoagulation. If the patient requires urgent surgery and has an elevated INR, administration of 5 milligrams of vitamin K given orally should be reduced the INR within 12 to 24 hours. Preoperative medication, all anti-anginal medication should be continued up to the morning of the surgery. Antihypertensive should be also continued. Digoxin should be given in the morning of surgery if used for rate control. And oral hypoglycemic medication should be withheld for 24 hours prior to the surgery, which allow for early morning dose of before the surgery. Any medication that affect renal function should be withheld, like thiazide and loop diuretic. Antiarrhythmia therapy should be continued until the time of the surgery. Statin also should be continued. Stress dose of steroid are indicated in patients on chronic steroid therapy or usually for COPD and autoimmune disease. Prophylactic antibiotic, first generation cephalosporin in CABG, first generation cephalosporin plus vancomycin in valve surgery. Mild sedation on call to the operating room, midazolam also the patient will benefit from it. This is the blood setup guideline for open heart surgery. If the patient going to minimally invasive CABG without pump, type and screening, and if the patient going to open heart surgery, weight more than 71 unit, less than 72 unit, reoperative 3 unit, ascending aortic surgery 3 unit, descending aortic surgery 6 unit. In my hospital, we not apply for this guideline. All patients will have at least 4 unit standby. This is my reference, and this is the end of my presentation. If you have any question, you are free to ask.
Thank you so much, Dr. Salem.
Okay.
Is there any question from the audience?
Sorry, Dr. Salem, I have one question. I believe you talked about females and their increased risk for cardiac surgery. My connection at that point was having some issues. Can you repeat the points that you mentioned?
Just wait. Female has a mortality rate than after adjusting the comorbidity and low body surface. Possible explanation is small coronary. Coronary is small, and when you anastomose the coronary, that it will be more surgical error, and it will be thrombosed because the small diameter, and also the patient present to seek medical help after advanced stage of the disease. This is the explanation.
Okay, thank you. This applies for CABG. Are you aware if this carries over to other types of scenarios in cardiac surgery? For
No,
example,
only for cabin. That
okay, thank
the
you.
risk of cabin.
Okay, well, thank you so much, Dr. Salim. We'll take a break of 5 minutes, then we will continue with the cardiac anesthesia presented by Dr. Jumana. Thank you, guys.
Assalamu alaikum, good afternoon. I think we're ready to proceed to the second lecture. It's going to be about cardiac anesthesia presented by Jumana. Jumana, do you have anyone to supervise your session or?
No, actually.
That's fine. Whenever you're ready, please go ahead.
Okay, so I am Jumana Shahbaz, cardiac resident R2 in Prince Sultan Military Medical City in Riyadh. Good afternoon. Good afternoon, everyone. And today we will be talking about the cardiac anesthesia. This is our outline. First, we will talk about the preoperative assessment done by the cardiac anesthesiologist and what to do about the chronic medications most cardiac patients are taking, and the preoperative medications to be given to the cardiac patients, intraoperative monitoring, and induction of anesthesia and maintenance of anesthesia, and the BIS monitoring. In the preoperative assessment, we need to make sure to do a thorough physical examination and the history, and also explain to the patient the techniques of the monitoring we will be doing inside the OR and the post-operative ventilatory support. The goal of this step is to identify any potential problems that might require further workup or the problems that could influence the intraoperative management. First, we'll do with the history. So we'll ask about cardiac symptoms, significant comorbidities, previous anesthetic or surgical experiences, allergies, medications, and recent use of steroids. For the examination, we need to concentrate on the intubation concerns such as loose teeth, ability to open the mouth, the laxity of the jaw, the length and width of the neck of the patient, and how obese is the patient. Say you went in and you did a complete and thorough history taking from the patient. Now you need to classify your patient so that you can communicate to the other anesthesiologists and the surgeons about the risk or the status of the patient. So the question is, what is the preoperative scoring system anesthesiologists use to classify patients? That's a question to the audience.
May I answer?
Who are you?
This is Sireen Mushid.
Hello, Sireen. Okay, go ahead, please.
We can use STS score.
What is that?
The scores using for classifying the patients. About the risk, their risk, their percentage of their mortality post-op and the risk.
I see, okay. From an anesthesiologist point of view, more specifically, is anyone familiar with the American Association of Anesthesiology, ASA, scoring? Okay. In this scoring system, we basically ask we get the scoring system from the answers of the questions in the history. So as I said, we ask about the comorbidities, the general condition of the patient, and from there we can classify the patient into 4 classes. So we have ASA1, ASA2, ASA3, and ASA4. The ASA1 is a normal, healthy patient. He must be non-smoker and no alcohol use or at least minimal alcohol use. ASA2 is mild systemic disease. In this one, the smoker and the social alcohol drinker, pregnancy, and obesity from 30 to 40 kilogram per is considered ASA2. ASA3 is severe systematic disease. ASA4 is severe systematic disease that is a constant threat to life, such as recent history, which is less than 3 months of MI, CVA, or TIA. So this is the score anesthesiologists use as American Society of Anesthesiologists to classify the patient's physical status before the operation. Say we did a good physical examination. وزي ما قلنا, we looked at the things that could make the intubation difficult. Now you would like to report to your senior the difficulty of intubation. What are you expecting the difficulty for intubation will be in this patient or that patient. Does anyone have any idea how can we assess the difficulty of intubation?
We can use the Mani-Bat score.
Yes, and what is that score?
I think it's for classification.
Okay.
The visibility of the
Excellent. So we have 4 classifications. The first classification in the Mani-Bat score is complete visualization of the soft palate. And the class 2 is complete visualization of the uvula. Class 3 only to be able to visualize the uvula. And class 4 is soft palate is not visible at all. طبعا from class 1 to class 4, it is more difficult intubation. Okay, let's talk about the chronic medications that the patients are using usually in cardiac surgery or cardiac patients. Now, the anesthesiologist should be able to instruct the patient on which medication to continue or stop or take in different doses. As my colleague have mentioned before, I'm just going to go quickly about it. So, antihypertensive medication and all anti-anginal medication. What should we do with them? Stop them, continue until the day of the surgery? Choose. He just mentioned, so I don't want to repeat. I just would like to ask the audience. Can someone answer?
For the antihypertensive medications, it depends on what the medication. For example, ACE inhibitors, we would stop it 24 to 48 hours before the surgery.
Excellent. Okay, this is an exception, but in general, the antihypertensive and anti-anginal?
We will continue with it.
Exactly, ممتاز. So continue all antihypertensive and anti-anginal medication up to and including in the morning of the surgery. طبعا زي ما قالت the exception include ACE inhibitor and ARBs. They should be withheld in the morning of the surgery because they to reduce the risk of the lower systemic resistance in the perioperative period. After the antihypertensive, we have insulin and oral hypoglycemic medications. We should tell the patient to stop taking it in the morning of the surgery because the blood glucose must be obtained on the arrival in the OR and checked frequently during surgery by the anesthesiologist and to be covered with the IV insulin. So they should not take anything in the morning of the surgery by themselves in regarding to insulin and oral hypoglycemic. Okay, after that, we have a lot of recommendation regarding the cessation of anticoagulation and antiplatelet. So warfarin should be stopped at least 4 days before the surgery. Aspirin, we should stop it 3 to 5 days before the valvular surgery, which has no coronary disease. However, if the patient has a coronary disease, aspirin should be continued, and it is believed to have little impact on the perioperative bleeding. طبعا continued on the dose of 81 milligram per day. Clopidogrel should be stopped 5 to 7 days before any elective surgery, but may be needed to continue in patients who have drug-eluting stent. So clopidogrel, you will stop it. However, if you had a patient who did a PCI recently and they have a drug-eluting stent, maybe you will need to continue the clopidogrel or stop it for a shorter period, shorter than 5 days. Unfracturated heparin may be continued into the operating room, as he said, only for the patient who has very critical coronary disease. Otherwise, you stop the unfractionated heparins 4 hours before the surgery. The last dose of the low molecular heparin should be given 18 to 24 hours before surgery. Patients should not receive Fonda for at least 48 hours before surgery. The last one is the 2B, 3A inhibitors, which should be stopped at least 4 hours prior to surgery. Okay, so preoperative medications. There are certain preoperative medications the anesthesiologist is supposed to give the patient, whether when he is brought to the to the operating room or before. So first of all, we need, once the initial IV lines are inserted, we need to start the IV low doses of midazolam, 1 to 4 milligram IV, can be given to reduce the patient anxiety and produce amnesia, to allow safe insertion of additional monitoring lines without producing hemodynamic stress. So this is one of the goals. If you have an operation, the patient, say, with a low ejection fraction, and he's a very critical patient, it is important for the anesthesia to be aware of that, so they can introduce a low dosage of midazolam for the safe insertion of the lines without hemodynamic stress. Because if you had the patient and you started introducing arterial lines and femoral lines on the patient without giving the midazolam, it could cause a significant hemodynamic stress. Okay. And also, we need to give prophylactic antibiotics. It should be given within 1 hour of the skin incision. If you are giving vancomycin, starting 2 hours. Okay, so now my patient is ready. He's in the OR. I am the cardiac anesthesiologist. What I need to do is to connect my patient to all the machines of the intraoperative monitoring. So okay. The things we need to connect the patient to is ECG, especially lead 5 and lead 2. Atrial line, we need to put an atrial line for ABG, or if a patient needs intra-aortic balloon pump to be inserted. We need the PA and CVP catheters, and to monitor the temperature, usually using a lower esophageal probe. We need to monitor the urine output, end-tidal CO2 and pulse oximetry, and also TTE. All of those are to be done by the anesthesiologist. Okay, this is the main part of our topic, which is the induction and maintenance of anesthesia. So cardiac anesthesia is provided by a combination of medications, which are induction agents, anxiolytics, amnestic, and analgesics, muscle relaxants, and inhalation anesthetics. First of all, we are going to start with the induction. Induction agents include propofol, thiopental, ketamine. Most commonly, the most common induction agent used is a combination of propofol, which is a narcotic, and a neuromuscular blocker. We need the neuromuscular blocker to provide muscle relaxation, so you can do the intubation and prevent the chest wall rigidity that is associated with high dose narcotic inductions. There is one combination of for indication that is interesting, although it is rarely used. Ketamine given with benzodiazepine is very helpful in patients with compromised hemodynamics or tamponade. So if you had a patient with compromised hemodynamics, or a patient is like an emergency tamponade, you can give ketamine with benzodiazepine as an induction agent or induction combination, because ketamine does not produce any myocardial depression. However, it does have a stimulant effect. It will make tachycardia and also hypertension, but that's why we actually combine it with the benzodiazepine, so we can attenuate those tachycardia and hypertension effect of the ketamine. Okay, after you have done the induction of anesthesia, the next more important point is the maintenance of anesthesia. So anesthesia is maintained by giving additional dosing of the narcotics and the muscle relaxants we started with in the induction. We keep giving additional dosing with combination with anxiolytic, whether midazolam or propofol, and also an inhalation agent. So the narcotics, the most commonly used narcotic is a low-dose fentanyl. So fentanyl, low-dose fentanyl has a duration of action of 1 to 4 hours, which allows patient to awaken within few hours of the completion of the operation. The anxiolytics, we have midazolam and propofol. Midazolam has an elimination life over 10 hours in patients undergoing cardiac surgery. So we do not use midazolam unless the patient is pre-bypass period. So it can take 10 hours to be eliminated. However, propofol is usually given at the termination of the cardiopulmonary bypass and continued in the ICU. Why? Because the difference between the propofol and the midazolam is the half-life and the duration of action. So propofol has much lower duration of action than midazolam, and you can awaken the patient whenever you feel necessary, rather than midazolam that will need to take a reversal agent. So propofol, another point, plus point for propofol is that it can be used to control post-bypass hypertension. That could be encountered in the ICU because the propofol has strong vasodilated properties. However, whenever the patient is stable, the propofol is turned off and the patient is allowed to awaken little bit by little bit. This is for the anxiolytics. And now let's talk about the inhalation agents. The inhalation agents provide muscle relaxation and also unconsciousness. However, they have variable effects on the myocardial depression. So we need to know each medication and what is the effect of them on the myocardium, so we can titrate those effects and not encounter any side effect. Okay, agents commonly used include sevoflurane, desflurane, and isoflurane. They are generally given during bypass to maintain the anesthesia and reduce the blood pressure. Desflurane and sevoflurane, they have one plus point, which is they allow for early extubation because they have less lipid solubility and the rapid onset of action, and they are quickly reversible. So any medication in general that has a lower, less lipid solubility will have a rapid onset of action and will be quickly reversible, allowing for early extubation. When we talk about the inhalation agents, nitrous oxide comes to mind as a very famous inhalation agent. However, we must know that in cardiac surgery, a nitrous oxide is completely contraindicated because it reduces the amount of oxygen that can be delivered to the heart, and it also may increase the pulmonary artery pressure, PA. Okay, muscle relaxants. We must be giving the muscle relaxants throughout the operation for two main reasons. First, to minimize patient movement, but also to suppress the shivering during the hypothermia. The using of the hypothermia is an important way in cardiac surgery to reduce the demand of oxygen. We have to give adequate muscle relaxation because it will, there is one plus side for it. It reduces some of the paraspinal muscle soreness often noted after cardiac surgery due to the sternal retraction. So if you have a good anesthesiologist, he will be able to keep adequate muscle relaxation given to the patient, and he will help you even after the operation by having less complaint of the muscle soreness from the patient. Okay, those are, as I said, it's important to know the hemodynamics effect of the commonly used anesthetic agents. Let's see, we have, as we said, induction agents, anxiolytic, narcotics, and muscle relaxants. First of all, the induction agents, as we said, the most commonly used induction agent is propofol. You can see that propofol is very suppressive of the myocardium. It will decrease everything, the heart rate, the contractility, the SVR, the resistance, and the blood pressure, all will be decreased. The anxiolytics, we have midazolam and propofol, both are famous choices. The propofol, as we said, the midazolam does not affect the contractility. The most important point, differentiating point between midazolam and propofol as an anxiolytic is the what? It just said it. Why do we give midazolam pre-bypass and we give propofol post-bypass?
Because midazolam has longer time, longer action.
ممتازة تسنيم. Okay. Narcotics, we have the fentanyl. Muscle relaxants, we have rocronium and succinylcholine. Rocronium is a very popular choice because it's very rapid. We love rocronium. R is for rapid because it's very rapid onset, and also look, it has literally like no significant effects on the hemodynamics, so it's very safe. Succinylcholine is an important one. I don't know. Succinylcholine is an important one. Cannot see. Yes. Succinylcholine is an important choice for the muscle relaxant because it is unlike the rocronium and all the other muscle relaxants. It does not work for the duration action is very. The duration action is less than all the other muscle relaxants. Now we are going to see. Okay, so this is the dosages and the metabolism of the commonly used anesthetic agent. For the anxiolytic, as we said, propofol only 20 minutes, midazolam 10 hours. The narcotics actually take from 1 to 4 hours, except remifentanil, it takes only 10 minutes. The muscle relaxants, as you can see, all of them are up to 1 hour or more, except for the succinylcholine, it takes 5 to 10 minutes in the duration of action. So that means you would need to re-give the succinylcholine every 10 minutes. However, chromium, you can give it each hour. Right. Now say I put the patient, I did the induction, I put the patient into sleep, and I would like to maintain that. How do I know that I am giving just the right amount of anesthesia? So the patient does not gain awareness inside of the OR while the procedure is going. And also I don't overdose the patients on all of those drugs. And the question is how to titrate and minimize the amount of medication required to maintain adequate anesthesia without overgiving or undergiving.
They use the PSI.
Perfect. So we do actually have this thing, which is a device we use to monitor. What does it stand for? It actually stands for bispectral electroencephalographic monitoring. It can be used on and off pump surgery to minimize the amount of medication required to maintain the adequate anesthesia, and also minimize the hemodynamic alterations and prevent the awareness. This device is helpful mainly during bypass, because when you do bypass, you have hemodilution, which increases the effective volume of the distribution of the anesthetic medication. بالتالي it might necessitate redosing. So you can see that by this device, you can see when do you need to redose your patients on your anesthetic medication. طبعا the dose and selection of anesthetic agent must provide adequate anesthesia and analgesia during surgery. But why do we not want to give too much anesthesia and too much analgesia? Because we would like to allow for early extubation. Early extubation in the operating room, or more frequently in cardiac surgery, early extubation several hours after the arrival in the ICU, we would like the patient to wake up. So you have to maintain like a balance between those two main points. Okay, say I was in the OR, I am the anesthesiologist, I had a BIS device. What is the bispectral index system value that is recommended for general anesthesia? It's a system, it's an index system, so there are numbers. There is a certain value that I am targeting. I would say my patient is in good general anesthesia state. He is not deeply sedated or over sedated, and he is not going to be awake and recover consciousness. Is anyone familiar with the bispectral index system?
I think it's from 30 to 50.
Okay, that is a little bit close, but let's see. It is not from 30, it is 50, around 50. So 40 to 60 is the recommended range of the general anesthesia. This is the indexed value system. It measures the depth of the sedation. If it's 0, so it's a flat line EEG. If it's 0 to 40, this is deep hypnotic state. The memory function is lost, so amnesia, and increasing burst suppression. If it's from 40 to 60, this is the range for the sedation, general anesthesia. If you take it up from 60 to 90, this is the recommended range for sedation. If it's 100, the patient is awake and the memory is intact. Okay, that concludes the lecture. Thank you. Does anyone have any questions?
I just have one comment regarding this BIS. In our hospital in King Faisal, we use another system called PSI, which stands for Patient State Index.
Mm-hmm.
and the optimal anesthesia is from 25 to 50. So a different measurement.
Oh, I see. So it's a different
Different system.
different system used.
Yes.
Okay, thank you so much for that information. Does
Thank you.
anyone have any other question? Thank you. Bye.
Thank you, Jumana, for the excellent lecture. I just wanted to say that cardiac surgery is a communication kind of surgery. It goes between the surgeon, the anesthesiologist, and the perfusionist. So I wish that you would have brought in someone from the anesthesia team to communicate and help us understand some of the verbal and nonverbal communication that happens during the OR. But anyways, otherwise, excellent presentation. Thank you so much. Any other question for Jumana? Okay, I guess this takes us to the end of this lecture. Thank you so much and see you next week.